Good morning. It's a real pleasure to be here, to be invited to speak, and I'd like to thank Margaret and Paul and company for inviting me, and it's certainly a pleasure being back in your beautiful city. The balmy weather certainly has me feeling quite at home, but really it's great to be here, and also to visit this institute. I've certainly been enjoying reading the work that's come out of it for a very long time, and so it's great to be here. I have a lot of territory to cover, so I'm going to jump right in. Really what I want to do today is to talk to you about what happened in Vancouver. I want to tell you a bit of a story, and in doing so I'm going to describe a public health emergency that was declared, but also the response to it. And in doing so I want to share with you some of our successes, but also some of our failures and how we tried to address that to eventually end up with what I think is a fairly effective response, really rooted in a fairly balanced approach to problematic drug use. First, let me introduce you to the downtown Eastside. I'm sure many of you heard about it. It is Canada's poorest urban postal code. It is the home to an estimated 5,000 people who use illicit drugs, primarily injectors. They live in a 10-block area. There is a massive open drug market, which you can see here. But also importantly, there is a large network of alleyways that operate behind the single-room occupancy hotels and the shops. And really, this became an open-air injecting environment. People would use the little injecting niches, the doorways behind the shops, to inject so that when the police would pull up at the end of the alley to see if people were in there misbehaving, they couldn't be seen. But I'm sure you could understand this really made for some horrific injecting conditions. Also very important to the Vancouver epidemic is the network of single-room occupancy hotels. These were originally developed to accommodate individuals working in the resource-based economies, such as forestry, who would come out of the bush after working for weeks on end. They wanted cheap accommodations for just a night or two, and accordingly there were taverns on the main floor, an active sex work industry. When those resource-based economies dried up, this really became housing for the urban poor, but also during the 80s, when there was a lot of nice language around deinstitutionalizing the mentally ill, they were promised community care. The community care never happened, and so they ended up living in the downtown East Side. And these hotels are famous for their horrible conditions. Fortunately, increasingly, they've been taken over by NGOs and Housing First programs, and they're gradually getting improved. In 1997, we experienced what has been described as the most explosive epidemic of HIV that's ever been observed in the developed world, with an annual incidence of about 19%. This was largely driven by the injection of powder cocaine, which had hit Vancouver. People were injecting up to 20, 30 times a day. A typical cocaine run would be 3 or 4 days without sleep, followed by 2 or 3 days of rest, and then going back out and starting all over again. There was also a massive situational unavailability of syringes, primarily because the syringe exchange had a number of deficiencies, which I'll talk about shortly, but it was also designed for a heroin using population, injecting 2 or 3 times a day. At the same time as we experienced that epidemic of HIV infection, the province of British Columbia was experiencing about 1 overdose death per day, and that's a province with around 4 million people. And this is a picture of an event called 1,000 Crosses, where the Vancouver Area Network of Drug Users, the drug user organization VANDU, erected 1,000 crosses in a park and invited people to come in and write the names of loved ones they had lost as a means of demanding action in response to this problem. Like many cities experiencing problematic drug use, the primary response has been enforcement of drug laws at the street level, and this has really gone on for decades, and for a long time the policy was one of containment. You can do that in the downtown East Side, but you can't do it elsewhere. So the combination of this active drug market, this open air injecting environment, everybody in these single room occupancy hotels, the containment by police made for a real public health disaster, but it also afforded some good opportunities for a public health response. The Regional Health Authority, in response to the overdose and HIV epidemic, declared a public health emergency. However, after a few years of inaction, the municipal government was quite progressive at that time, and they launched this document, the Framework for Action, a four-pillar approach to drug problems in Vancouver, which is modeled after the Swiss approach, whereby they're trying to seek some rational balance between prevention, treatment, enforcement, and harm reduction, which is a tricky thing to do, as I'll describe shortly. They held consultations throughout the city, they got the support of various stakeholders, and moved forward. It was around this time that my colleague and I, Evan Wood, launched the Urban Health Research Initiative, and we've been responsible for evaluating many of the initiatives of the four-pillar approach. So I'm just going to take a moment and describe our program for you, as I'll be sharing lots of results from our work throughout this talk. Our flagship study is the Vancouver Injection Drug User Study. It's a prospective cohort of over 1,000 HIV-negative individuals who inject. It's in its 14th year. It's funded by the U.S. National Institutes of Health. We've enrolled and followed over 1,500 individuals, although the median age is 39, a third of the cohort is now dead. We also, with funding from NIDA, are following the Access cohort, which is 1,000 drug users who use drugs other than cannabis who are living with HIV. If you're in VITUS and you seroconvert, you move over to Access. We are also following over 500 street-involved drug-using youth in a separate but adjacent neighborhood called the ARISE study, the At-Risk Youth Study. And as part of the scientific evaluation of Insight, Vancouver's supervised injection site, we have randomly selected and followed over 1,000 safe injection site users. The methods for all these cohorts are exactly the same. At baseline and semi-annually, people complete a very lengthy interviewer-administered questionnaire. They provide a blood sample for diagnostic testing, primarily of HIV and hepatitis C. And if you're HIV positive, we monitor your disease progression. Then people go on and complete a lengthy nurse-administered questionnaire about their health status. And in the province of British Columbia, everybody has a personal health number. And with people's informed consent, we're able to use those personal health numbers to link to a variety of databases to get ascertainment of various outcomes, including hospital utilization, admissions to addiction treatment. Now, we've built several layers under these studies, including a program of laboratory and basic science research. We have a fully funded and vibrant ethnographic social science program, and we've recently added a number of spatial methodologies, including GIS and qualitative mapping activities. We have a policy research and a knowledge transfer program. I'm not sure what the language you use is here, but we refer in Canada as, we talk about knowledge translation and transfer. That means translating research, knowledge gained from research into language that general audiences and policymakers can understand, and then finding ways to transfer that by creating things like policy briefs, plain research summaries, and trying to interact with a broader audience and trying to make sure we do something more than just populate the shelves of libraries. We also have an active community-based research program. All our community-based research studies are done in collaboration with drug user organizations in Vancouver. We have a number of studies with the Vancouver Area Network of Drug Users, and we also do similar work in Thailand. And we use this cohort infrastructure to support a number of clinical trials and intervention studies. So when the four pillars approach was launched, really the police were in the best position to do something. They were fully funded, they were already very active, and although we had sort of sought this balanced approach, the first thing they did was launch a huge crackdown, which involved trying to really address the public disorder problems. And that was evaluated by us through a number of ways, including this ethnography by Will Small. And really we found what you found here with your evaluations of similar activities. We found widespread displacement of drug users. These activities actually helped to seed new drug markets in other parts of the city. We saw increases in risky injecting, reductions in access to sterile syringes, and a lot of frustration experienced by many outreach workers and healthcare professionals who could no longer find the people that they had worked hard to establish relationships with. Unfortunately, the police were also positioning their cars outside of various low threshold harm reduction programs such as this one, and would arrest people directly out front. Not surprisingly, our evaluations showed that when we looked at before versus after crackdown like Operation 24/7, we saw very large and significant declines in the number of syringes that were being distributed in the neighborhood. Just going back a few years, I think it's important to note that harm reduction didn't really start out very well in Vancouver. This is a now famous study called Needle Exchange is Not Enough. It was an early study of the outbreak, and what this study reported was a simple cross-sectional association between being a frequent needle exchange user and being HIV positive. It's now cited throughout the world as being a study that somehow proves that needle exchange causes HIV infection. So one of our first tasks, and certainly in Vancouver as well, this led to all kinds of headlines such as needle exchange doesn't work, despite the fact that needle exchanges are now endorsed by virtually every major medical and public health body in the world. But we were very interested in trying to unpack this problem and find out, well, how did Vancouver experience this explosive epidemic of HIV in the presence of a very large needle exchange? And when we looked at predictors of high-risk syringe sharing in this setting, what we found is that people who reported difficulty accessing syringes were over 3 times more likely to share syringes. We then looked at the reasons for difficulty accessing syringes, and one of the factors that people most commonly cited was that the needle exchange was closed. The needle exchange at the time had such pressure on it from business improvement associations and neighborhood groups to recover as many syringes as they distributed and to not contribute to disorder in the community. Sadly, they had this crazy idea that if they closed the needle exchange at 8 p.m., they could somehow denocturnalize the entire downtown Eastside, like the party would just stop because the needle exchange was closed, which I'm sure, as you can appreciate, when your drug of choice among most injectors is cocaine, you could see why this would be hugely problematic. Also, problems were a number of restrictive policies. For example, you had to have a needle to return in order to get one. They weren't giving out loaners, that kind of thing. So fortunately, we worked very hard with the Regional Health Authority to try and share this data with them and encourage them to redesign their needle exchange, and to their credit, they did. Importantly, they decentralized and expanded the needle exchange. Every health clinic in the area began distributing syringes, and they also began to involve drug users in the distribution of syringes through a variety of mechanisms. They moved away from a focus on exchange towards a focus of distribution. They expanded the number of sites and methods used for distribution, including foot patrols. They removed the limits on the number of syringes that could be obtained, so people could literally grab hundreds of syringes at a time. They removed the restrictive one-for-one exchange rule. You didn't have to have a used rig to get a new one. And very importantly, they separated distribution and recovery functions, so the people distributing syringes no longer had to worry about recovering them. We recently evaluated this in this paper published in the American Journal of Public Health, and here you can see that the period of policy change was associated with large declines in syringe boring, which persisted in a multivariate model, as well as large declines in HIV incidence after adjusting for changes in drug use patterns and other known risk factors. Also, quite central to the response in Vancouver has been drug user activism and peer-driven interventions. For example, when right before the framework for action was developed, a local neighborhood group supported by a number of architects who really wanted to gentrify and redesign the downtown Eastside lobbied the City Council to declare a moratorium on the creation of new programs for drug users. So Vandu responded by delivering a coffin to City Council, and they erected crosses all over the lawn of City Hall, and the moratorium was immediately lifted. But they also really helped extend the reach and effectiveness of local public health programs by going to places where other public health workers weren't going. So for example, they would go at the wee hours of the night and the morning and make contact with the highest risk injectors in the alleyways to provide them with sterile syringes, first aid. They were all trained to provide emergency response in the event of overdose, etc. They also very early on erected a exchange tent right at the corner of Main and Hastings that opened the minute the fixed exchange closed. We subsequently evaluated that to compare people who were and were not accessing the Vandu needle exchange tent, and we found that the people who were visiting it possessed markers of risk for HIV infection, people who injected in public, and they were also helping to encourage safer syringe disposal. And we've seen similar benefits for their alley-based patrols. Another key feature of the framework for action response was the creation of this facility. This is Insight. This is Vancouver's Supervised Injection Facility, which, after much public debate, finally opened in 2003. It was opened as a scientific pilot study. That's how it was regulated. It was only allowed to open, and people were exempt from provisions within our federal drug laws, provided that it was subjected to rigorous evaluation. The facility is open 18 hours a day from 10 a.m. till 4 a.m. in the morning. There are 12 booths for injecting. They supervise anywhere between 600 to 1,000 injections per day. The objectives are very simple, much like the Sydney Injection Center. The goals were to reduce public disorder associated with injecting in public, reduce risk for transmission of various infectious diseases, including abscesses and soft tissue infections, which in our setting account for the majority of emergency room and acute hospitalization utilization by drug users. As well, the program sought to increase contact with external health and social services and reduce risk for overdose. Sadly, before any evaluation data was available, the program became heavily politicized. We had a visit from John Walters, the White House Office of Drug Control Policy Director, who, again, before any data was even available, declared that Insight was nothing other than state-sponsored suicide. But we were able to, through the existence of our cohort infrastructure, we're able to quickly produce some evaluation data, including this paper, which documented some changes in public disorder in the neighborhood. This dotted line shows you the opening of the facility. This is the number of weeks, and you can see within the first 12 weeks, the number of people using the facility leveled off at about 500. It's much higher now. Then we had an ethnographer walk around the neighborhood in a 10-block area and do systematic field counts of the number of people who were injecting, the amount of injecting litter, as well as the number of police on the streets. And as you can see, as the number of drug users went up, the amount of people seen injecting in public went down. In order to validate the counts, we correlated the counts of discard syringes with those being collected in the city disposal boxes, and they correlated well. We then ran a series of regression models, knowing that people would say, well, you know, police presence could have done it. You did this work in September when it starts to rain in Vancouver. So we ran a series of regression models where these markers of disorder were the dependent variable. We adjusted for police presence and rainfall obtained from the Environment Canada statistics, and the number of people using the facility each day reliably predicted improvements in each measure. We also documented changes in syringe sharing associated with the facility. Specifically, those who were using the facility on a frequent basis were about 70% less likely to report syringe sharing. Again, we took advantage of the pre-existing cohort. We compared rates of syringe sharing before and after the facility among those who did eventually use the facility and those who didn't, and the rates were the same, meaning the protections that we observed in this study really only emerged after the facility opened. We also, using a record linkage, we obtained hard data on the number of people registering into detoxification programs and found that people who used the facility more frequently were more likely to enter a detoxification program. We followed that up with this paper, and again, using a record linkage, we compared the number of people who entered a detoxification program in our cohort of injection site users before the Insight opened and after. And in a multivariate model, we found that there was about a greater than 30% increase in detoxification program use. And people who went into a detoxification program did what we hoped they would do. They then went on to enter more abstinence-oriented addiction treatment programs. Then using the database within the facility itself, we were able to determine that those who went to a detoxification program, then went into addiction treatment, reduced their reliance on the facility, as there was a statistically significant decline in re-entry into the facility after one had been admitted to a detox program. Recently, we sought to evaluate whether the facility was having impact on rates of overdose deaths. And for this study, we accessed data from the BC Coroner's Office on all illicit drug overdose deaths in the province of British Columbia. And Brandon Marshall, a brilliant young researcher, used GIS methods to map all these overdoses in the city of Vancouver. This yellow dot here is the supervised injection facility, and you can see that in this roughly 5-year period, the heaviest concentration of overdoses were right around the injection facility. Then we used data from our cohort which showed that the people who used the facility, who were likely to use it on a daily basis, lived within 3 blocks of the facility. And so we determined that a 3-block distance was roughly 500 meters, so we created a custom map that included every block that had a centroid within 500 meters of the facility. That became our area of interest, and we used the rest of the city as a control. What this map shows you is the incidence density of overdose deaths in the period before Inside opened and the period after. The darker the color, the heavier the density. You can see that there was a reduction in overdose deaths in the period after. And when we evaluated that, it turned out that the reduction was around the facility was 35%, and while it was only 9% in the rest of the city, and that was non-significant. We've also exported data to other researchers who have demonstrated that Vancouver's injection site is highly cost-effective. It's estimated that over a 10-year period it would result in approximately $18 million in cost savings. As well, we've conducted a number of studies to show that Inside is not having any of the anticipated negative effects. It hasn't resulted in an increase in drug-related crime. It hasn't promoted initiation into injecting among youth at high risk to inject. And it hasn't exacerbated drug use patterns in the community. So while the facility seemed to be a success from the point of the evaluation, and we had engaged in a whole variety of knowledge translation activities, including plain language summaries and reports and policy briefs and face-to-face briefings with various policymakers. And the Vancouver Police Department itself was supportive and actively referring people to the center. There were those who were quite opposed to it, including the Canadian Police Association. And we were very concerned because at the time the 3-year exemption was about to expire, Stephen Harper's Conservative government had obtained minority government status and had made a number of negative comments about the facility. And then literally 3 hours before the federal health minister made his announcement about the future of Insight, on the Friday of a September long weekend, the Canadian Police Association issued this response saying that this harm reduction focus had led to unprecedented levels of crime, despite the fact that the VPD's own statistics show that crime had actually remained stable or declined in some senses. And then within a few hours, the health minister himself declared that he was going to extend the pilot for another 18 months, but he was cutting funding off for the evaluation. I guess he didn't like the results. Then to our surprise, one morning this paper appeared in the Institute of Global Drug Policy. I'm sure most of you haven't heard of it. That's because this paper appeared in Volume 1, Issue 1, and it's not really a journal. It's actually a website operated by the Drug Free America Foundation, and it's a remarkable innovation because really what it is a website posing as an online open access journal. But if you look at it and flip through it, there's not a single paper there involving original data involving human subjects. In fact, it's just a series of papers that are rants against harm reduction. When you call the office, you get an office in Florida, which is the Drug Free America Foundation, and the website is also registered to the Drug Free America Foundation. And much to our surprise, the Institute on Global Drug Policy is very explicit about their mission, which is to create and strengthen international laws that hold drug users and dealers criminally accountable for their action. The Institute supports efforts to vigorously oppose policies based on the concept of harm reduction. And this paper that I was showing you is written by an individual who also has never published a paper involving human subjects, but concluded that our evaluation was entirely flawed, that the New England Journal of Medicine, the Lancet, were basically journals operated by harm reduction advocates, and that if you really carefully examine the data we produced, it's very clear that Insight is creating a number of harms and has no benefits. Unfortunately, it led to a number of headlines, such as this one in our national newspaper, declaring that harm reduction doesn't work. Fearing that the new conservative federal government would close Insight, the crafty NGO that runs the facility and 2 members of the Vancouver area network of drug users took the federal government to court. They put forward 2 arguments in the BC Supreme Court, one that closing Insight would violate the constitutional right to the highest attainable standard of health, and an argument based on interjurisdictional immunity, meaning that it was really the province that had the authority to determine what health services it would run, even if those health services contravened the national drug laws. And eventually the BC Supreme Court Justice Pitfield argued in favor of Insight, declaring that it did in fact violate the constitutional right if it was closed. He didn't argue on, he didn't offer much of a judgment on the interjurisdictional immunity argument. And although people were quite pleased, within a couple of days, the Minister of Health made this public statement, citing the paper from the journal, the Global Journal of Drug Policy and Practice. He said, "I think it's quite clear from my remarks today that there exists a significant degree of uncertainty in the research." Sounds like climate change, doesn't it? "I can inform you today that I'll be asking the Minister of Justice to appeal Judge Pitfield's decision at the earliest possible opportunity." And it was at this point that the Conservatives closed our national office of the scientific advisor, had muzzled Environment Canada scientists, and done a number of other things that really offended Canadian scientists. So along with some people working in the area of environmental science, we formed the Coalition of Concerned Scientists. We issued a number of media statements about calling for an end to the politicization of science in Canada, which was successful in drawing attention to this problem. But when the case went to the BC Court of Appeal, the 3 justices actually ruled in favor of the interjurisdictional immunity argument, saying that the province had the authority to run this program despite the fact that running it violated some of our national drug laws. They said, we're not going to really say much about the constitutional argument, but we basically agree with it as well. But then the federal government again decided to waste more of our precious public dollars and decided to appeal this to the highest court in the country. And about 2 months ago, the case was heard at the Supreme Court of Canada. What was really interesting this time is that pretty much everyone stepped up to the plate to seek intervener status. And supporters of Insight included the Canadian Medical Association, the Canadian Public Health Association, and the Canadian Association of Nurses. And we are expecting a decision in the next 4 months. One unfortunate thing I must say about this focus on harm reduction and this whole kind of paralysis around its future is that it has truly prevented us from moving forward on other fronts. Look, you know, Insight is doing what it's supposed to be doing. It's met its basic objectives. It's a small pilot facility. It is by no means a panacea. And I think, as illustrated by our work on Overdose, its coverage is very limited. We don't have a comprehensive program of supervised injecting. The neighborhood could use probably at least another 2 or 3 facilities. But really, there's so much more we could do. But also this focus led some commentators to argue that really the 4-pillar plan had failed, that really all we had was harm reduction and policing. However, our own cohort data showed that over time there had been a massive increase in the number of people entering addiction treatment, in particular methadone, and there had also been, as indicated by the blue bars, a fairly significant decline in the proportion of people who were reporting difficulty accessing addiction treatment. And these trends were really mirrored by massive increases in expenditures in addiction treatment. Some of you may also know that Vancouver was home to a very long anticipated and expensive heroin prescription trial done by researchers outside of our group. The results were published not long ago in the New England Journal of Medicine, and like other heroin prescription trials, showed positive outcomes in terms of reduction in illicit drug use and illegal activities and retention in treatment. Sadly, there has been no access to the study drug post-trial, leading a lot of people to complain about whether this trial was ethical in the first place. And at this time, there really is no concrete plan to ensure the continuation of the program. One thing that was interesting about it was there was an arm that included giving people Dilaudid, and people in the trial could not distinguish between Dilaudid and heroin, and now there's going to be some efforts to try and see if we can't initiate a new trial that would involve comparing Dilaudid versus methadone. So at this point, I think it's useful to ask yourself, is harm reduction working in Vancouver? Well, clearly, I think many of the studies I have shown you suggest that the various programs are having some positive benefits, but really at a very broad level, when we look at the number of new HIV infections among folks who inject in British Columbia, you can see here in Vancouver there's been a very steady and rather dramatic decline. And while the overall trend is to a decline in other parts of BC, it's clearly not as dramatic. We see a similar effect when we look at overdoses over a 9-year period. Here in Vancouver, you can see a spike in the 90s and then a very steady decline, whereas in the rest of the province, there's been something of a decline, but it's clearly not as dramatic as we see in the city itself. We're not without our challenges still. I think some good things have been done, but things are ever changing. And I think, as I was saying to Paul yesterday, one of the really unique things about Vancouver and the North American and even the global context is we just kind of seem to have it all. You know, there's a lot of heroin, there's a lot of cocaine, there's a lot of methamphetamine, a lot of crack cocaine smoking. And in fact, when we looked in our cohort of injectors, we saw a very large increase in the number of individuals reporting crack cocaine smoking over a time period. In a recent paper, we looked at whether crack cocaine was a risk factor for HIV infection. And over the life of the Vancouver Injection Drug User Study, we looked at 3 different time periods. And as you can see in the most recent time period, those individuals who were reported smoking crack cocaine on a frequent basis were about 4 times more likely to seroconvert. And we don't really know exactly what the mechanism. It could be high-risk sexual activity, but that's something we're exploring, but it remains a challenge. And while we've seen a lot of crystal methamphetamine use increase in Vancouver, what's also been very interesting and somewhat unique is that a number of people are now injecting it, and injecting methamphetamine use has been associated with syringe sharing in our setting. An exciting new frontier, I think, for harm reduction is actually the provision of antiretroviral therapy to HIV-positive injectors for preventative purposes. In this paper, we used our HIV-negative cohort and our HIV-positive cohort to characterize the median HIV viral load in the cohort, and then we superimposed the HIV incidence rate. And in a multivariate model that adjusted for other risk behaviors, we found that community viral load was the strongest predictor of HIV incidence in this setting. Unfortunately, there are still a number of challenges related to the provision of antiretroviral therapy to those who are HIV positive. For example, we found that 44% of HIV-infected IDU who initiate therapy discontinue therapy prematurely against medical advice, and the strongest risk factor for premature discontinuation is incarceration. We've seen a similar effect for adherence, with the number of incarceration episodes being associated with poor adherence in a dose-dependent fashion. When we approached BC Corrections about this, including the medical practitioners within the jails, they said, oh, look, you know, right before people get arrested, their life becomes very chaotic. They quit all medications. They stop taking antibiotics, antidepressants, It's not our fault. We're doing everything we can. It's their problem. So then again, using our multidisciplinary approach, Will Small, our lead ethnographer, used our cohort to identify HIV-positive individuals who had initiated therapy prior to a recent incarceration episode. And he interviewed them about their experiences continuing therapy in jail. And what he found was that there was a whole host of problems that really predicted or really made it difficult to initiate or continue therapy in jails, including short-term interruptions in treatment during intake and transfers, delay in obtaining medications through institutional health care, very poor relationships between inmates and healthcare staff and concerns about privacy, as well as high levels of stigma, HIV stigma and discrimination. People were often beaten for being HIV positive, and disclosing your HIV status in a jail would also mean that you would not have access to the one rig that was circulating around the range. And there was also problems ensuring continuity of treatment upon release. Sadly, the government of Stephen Harper now is tabling a new tough on crime agenda, which involves initiating mandatory minimum sentences for drug offenses, nonviolent drug offenses, which I'm sure you all know have been well studied in the US and shown to be highly ineffective. And again, our group mobilized with other scientists to express concern about this, along with Aboriginal leaders in Canada. And that helped to generate a lot of attention about this problem, and it had it taken off the orders in Parliament right before the most recent election, but now that they have a majority government, I'm sure they'll move forward. But we've also been trying to really shed some light on the elephant in the room, which is the problem with drug policy, and really my colleague Evan Wood has really been taking the lead on trying to mobilize scientists internationally to speak out, feeling that we've all been a little too hush-hush about the very obvious failures of the war on drugs and the enforcement-laden approaches, which really mark the approach in most cities, and has created the Vienna Declaration with some other folks. And it's really just a call for drug policy to be based on science and not ideology. It's been endorsed by a number of prominent folks, including Nobel laureates and former presidents of many South American countries. If you haven't signed it, I urge you to go online and Google it and join in. I'm just going to conclude with a few summary points. I think it's fair to say that the body of science shows that harm reduction in Vancouver has been associated with some fairly significant declines in HIV transmission, fatal overdose, and other indices of drug-related harm. There's been, I think, a lot of factors that have been really key to success, but I think really having a multifaceted strategy. I don't think it's really possible to have a coherent four-pillar approach that's truly complementary. I think the evidence shows that policing too often interferes with the delivery of harm reduction programs. But certainly the removal of restrictive policies and programs was very helpful, and the involvement in drug users in program delivery and also in advocacy efforts were huge. I think multidisciplinary research has been really essential to demonstrating not only the effectiveness of harm reduction program and making a case for the continuation of innovative initiatives, but also identifying challenges. And I think in our context, although our group has often been criticized for being too advocacy oriented, I think us playing a role in the policymaking process, be willing to speak out, meet with police and business groups who really hate what we're doing has been very helpful. It's clear that drug enforcement, law enforcement, it has been a major barrier in our context, but I'm pleased to say that the Vancouver Police Department has really made a lot of gains. They have an official drug policy, they have a drug policy coordinator. We recently evaluated their efforts during the 2010 Winter Olympics and found no effect on use of harm reduction programs in the city, and again, they're actively referring people to the injection site and doing a number of other good things. Our harm reduction programs have really been under attack, and I hope it's clear to you today that we've really had to take some extraordinary actions to enact and preserve them, including taking the federal government to the highest court in the country. I think it's sad when the courts become the new frontier for the establishment of harm reduction, but really that's the reality. Unfortunately, while there's a huge amount of support for these approaches now in British Columbia more broadly, including among many enforcement personnel, we're still dealing with the huge international movement which would really prefer to see the preservation of the status quo. There clearly is need for some future work and directions. These include addressing the ongoing harms associated with crack cocaine and methamphetamine use, finding ways to scale up antiretroviral treatment and ensure that people really can remain on treatment even when they're in and out of jail, and also exploring alternatives to criminal justice approaches at the broadest level of policy. I just want to conclude by acknowledging the many people who use drugs, who participate in our studies and share their life stories with us, the folks who use Insight, our research staff, our partners at Vandu and at Insight and the Portland Hotel Society, the local Ministry of Health, and our funders, NIH, NIDA, and the Canadian Institutes of Health Research. If you want more information about our program, you can visit our website. We have there we provide a number of summaries of our research and plain language reports. We have a knowledge translation section as well. And if you need to get in touch with us, you can find out how there. Thank you very much.